Okay, welcome back everybody for our third hour of today's symposium. It's been really informative and I appreciate all of you who've stayed on. This is great. I'm really excited to introduce you to Dr. Catherine Faye. She shared with us some of the information that she'd be presenting, and it's a different approach than some of the things that we've been hearing. It's really delving into some of the research she is doing. So I'm really excited for all of you to hear her presentation. Dr. Faye's currently finishing up her OB/GYN residency in the spring at the University of Utah. And she's also a reproductive coercion researcher, and we'll be discussing the health implications that reproductive coercion has on our patients. The Academy of College of Obstetrics and Gynecology defines reproductive coercion as behavior intended to maintain power and control in a relationship related to reproductive health by some who is, was, or wishes to be involved in an intimate or dating relationship with an adult or adolescent. Dr. Faye will help us identify intimate partner violence as a disease, and we'll discuss reproductive coercion as a form of intimate partner violence.
I also will mention that I actually already completed my residency, mostly because I think it's important to know about the fellowship that I'm doing for people who aren't familiar with the kind of path of training, which I was not until I was in the middle of it. You can optionally, after specializing in obstetrics and gynecology, do additional subspecialization. And so I'm here on a family planning fellowship, which is a relatively new fellowship, but is now undergoing accreditation. And so that's to focus on abortion and contraception care. And it's kind of great that we have that in Utah. It also helps folks who are interested in a research career and an advocacy career. So there's specialized additional training for those paths as well, which is nice to know. I think that exists in medicine because it's not something that I knew existed until after I had gotten to residency. We'll be talking about reproductive coercion, which I would say is a facet of intimate partner violence. And you already got the definition, which invokes that power and control, which I think helps situate this phenomenon in intimate partner violence theory. I think that it's always nice to know what to expect in a presentation. There are going to be some quotations from survivors that can be upsetting because of the recounting of some of the tactics that are involved. If there are folks that want to sign off or whatever to take care of yourself, I totally understand that. But also that, this is a topic that I chose for research interest, not only because it's of academic interest, but I think that consent and choice are things that have affected everyone listening to some degree through the lives of the people that we advocate for or care for, but also in our own lives. So in terms of expectations, the main points that I would want folks to leave with is understanding that reproductive coercion is common, that violence is something that can be viewed as a disease, and that the interventions for reproductive coercion are routine. So more specifically, we're going to go through some definitions and recognition of RC. We're going to talk a little bit about viewing intimate partner violence through a public health model lens, and highlight some interventions that typically are geared towards primary care and OB/GYN providers, but I think are, again, important for everyone to know. Before we get into a definition, which we kind of got a little sneak peek of, I think there is a polling question for this. This is the ACOG definition, American College of Obstetricians Gynecologists, that basically says that it's behavior that undermines autonomous decision-making in reproductive health to maintain power and control. I think that that's still pretty abstract. So the things that we're more specifically talking about is removing or damaging a condom, taking out an IUD non-consensually, throwing someone's pills down the toilet, taking out a ring, taking off patches, not withdrawing if that was the form of contraception agreed upon, and also things that coerce or pressure towards conception or continuing a pregnancy or towards ending a pregnancy, as you can see here. Before we move on, I think it is important to know that the majority of data for reproductive coercion, as the same for intimate partner violence, is primarily from the study of heterosexual couples, with men as perpetrators and women as victims or survivors. And so that's not to say that there isn't evidence to suggest that IPV or RC doesn't occur among sexual minorities, with men as victims, or with family members or non-intimate partners as perpetrators. So you'll notice in the slides for the rest of this that the pronouns kind of correlate with where the data are coming from, but I don't mean that to silence other people's experiences. I think more specifically, besides the examples that we just looked at of what is reproductive coercion, it can be helpful to hear directly from people affected by it. So here are some of the qualitative data, or the type of data that really is drawing direct quotations from folks who have been affected. I try to highlight the things that really demonstrate to me some of the tactics that work here. So this, I think, is an illustration of coercion, of contraceptive negotiation silencing or condom silencing, where a coercive partner states that agreement to not use a condom is a demonstration of fidelity. Participants in this particular study really focused on describing that they were compelled to have sex without a condom to prove their loyalty or to avoid anger from their partner by suggesting a lack of monogamy. Here, I think this really shows the intensity of the threats, that these are forces that happen not just at the time of sexual activity, but after conception. They interrupt schooling. And here you can see that we're starting to appreciate that it really isn't particularly about achieving some sort of reproductive outcome, because this person goes and develops, other relationships after achieving this tactic of power of having this person become pregnant. Here, I think it's showing additional tactics, withholding transportation, other things that have been described in qualitative literature include making a patient eat before a procedure, being disruptive at a clinic so that a patient and partner are asked to leave. And I think here, while we don't know why this person might have had 4 other abortions, I would argue that at least some of that is likely correlated with the behavior of this partner. And those reproductive outcomes are things that we'll talk about in a minute. Here, I think that this is, you definitely don't need to read all this, but again, showing more range of tactics here, but really it introduces something. Can you see my cursor, by the way? Okay, I'm not just gesturing to myself here. That it introduces a term that I will talk about later, resistance strategy. So this person is hiding birth control pills in order to try to achieve their sexual and reproductive health goals. And I think that's a really important comment, and maybe correlates with Marty's presentation about like strengths kind of based approach to the qualitative. The data was just introduced in terms of quantitative data, so more of like the numbers that we think about that inform reproductive coercion, has really been informed by the reproductive coercion scale that was developed by Elizabeth Miller in 2010, based on her investigator experience as an adolescent medicine provider. And while I think that this has been really helpful to have a standardized scale to provide some pretty homogeneous data for a novel and kind of nascent field, there are some things that I think you might notice if you all are familiar with intimate partner violence screening tools that are a little bit different, and that potentially are things that might be changed about this scale in the future. Mostly like this kind of idea of intent. There's a lot of focus here on condom manipulation, but regardless, this has been amazing and really helping generate a field around reproductive coercion. And the reason why I introduce it is because it's echoed throughout the quantitative data that we have, including like here, what we understand is like the tactics that are the most common. These are directly pulled from Miller's later studies. Many other researchers have used this scale as well. So we see that some of the most common things that folks are reporting is that their partner is telling them not to use contraception or threatening them and kind of pressuring towards pregnancy. I think that it's helpful to take a closer look at one of these tactics before we kind of move on to other aspects of the talk today, again, trying to be time sensitive. And one thing that folks might have heard of before is stealthing. This is something that's come up in the press. And is often kind of known in medical communities more as non-consensual condom removal. And I think this is an important place to pause for a second, because it's a term that is thought to have originated in the men who have sex with men community. Really, again, highlighting that the kind of underlying constructs to reproductive coercion, just as with intimate partner violence, is power and control and not a specific reproductive outcome, because obviously pregnancy is not something that the MSM community is thinking about. I think really is highlighting for us that sexual violence is not about force, but it's really about consent, and that reproductive coercion is less about pregnancy and more about power and control. So to revisit this, and I think you all have already had some time with the power and control wheel, but in terms of some like fun facts around the background here, it's from Duluth, Minnesota, 1980. There are about 200 intimate partner violence survivors who were interviewed. And in those interviews, about 8 tactics came up time and again. The reason being is because they're incredibly effective tactics for asserting power and control. And how it was described to me when I used to be an intimate partner violence advocate and actually went to Duluth for a training is that perpetrators will often use these tactics here to assert power and control. When and if they don't happen, that doesn't happen, perpetrators engage in physical and sexual violence to again reassert power and control and then return to these inner tactics. And while you may notice that there's probably some overlap between what we've defined now as reproductive coercion, including coercion and threats, intimidation, emotional abuse, that I think it's something that warrants its own wedge here, particularly because it's a concept or phenomenon that the medical community didn't really recognize until about 10 years ago, and that it has specific implications for the type of healthcare we provide. And so separating it out and clearly defining what we're talking about and its downstream sequela, I think is really important in providing the best possible healthcare for folks. We're going to talk about how common this is. Is there a little question for this as
Dr.
well?
Faye, one comment I would make.
Yes. Yes.
So one thing on the power wheel that I think is really helpful is in communicating with our patients by understanding and really looking at the power wheel in our interactions and communications, knowing what that power structure is or what the outcomes are. I think it can help with our routine interaction of communicating with patients, asking questions like we had talked in previous sessions earlier in the year, just about how do we communicate, just normal conversations to elicit responses to find out somebody's personal situation. So kind of understanding what these power and control slots are, I think it makes it easier to think about questions that we might be able to make to eke out some information from our patients.
I guess it was kind of mind-blowing to me that 8 things could come up across hundreds of people's experiences. And it, to me, felt very liberating to highlight that this is happening because, again, it's so effective. And so a lot of times people, I feel like, get stuck in this mind space of being complicit or why is this happening or and what role do I play? But I think by labeling these for what they are as tactics that are utilized because of their efficacy in achieving power and control, that also helps build, I think, compassion and understanding. It's like I provide prenatal care. We screen everyone for antenatal depression and postpartum depression, and the prevalence for that or incidence of that is probably 8, I think it's like about 8%. And so we really have structured a lot of our prenatal care and postpartum care around capturing that population. And so I think that that to me informs our threshold for also asking about things like reproductive coercion. These are data from the CDC. And so I think we have to start because we don't have a lot of information about reproductive coercion with what we know about intimate partner violence. There is a significant amount of overlap between the two, but we'll start with IPV. So over a third of folks who identify as women report prior intimate partner violence, and 1 in 4 report some sort of IPV related, does that say injury? Impact. So that's things like presenting to the emergency room for care or having a diagnosis of PTSD. That's a lot of people. I think that one of the key principles that I was taught or thinking about intimate partner violence is that the folks who are represented in these figures include folks from all sorts of diverse socioeconomic, racial, and ethnic backgrounds. However, I think that there are risk factors that we should think about, and that some populations that are already vulnerable have higher risk of intimate partner violence victimization, such as those who are being trafficked, people with disabilities, racial and sexual minorities. And this intersection of oppressions really warrants recognition that I think is otherwise kind of unnamed in these figures here. For reproductive coercion specifically, so at a obstetric, in this one study by Clark, this is a Clark study, 16% of folks who were just showing up for like their pap smear, like just showing up for routine OB-GYN care, reported prior reproductive coercion. And that's what that scale that we introduced at the beginning here, that may also be underrepresenting how many people are affected just because of some of the things that I think can be modified in that scale. So that's a lot of people who are just coming in for sexual and reproductive health care. This range is also really broad based on the setting. So 10% is from a 2-question CDC-based national survey that I think probably underrepresents based on just asking only these 2 questions. And then 75% is asking people at a domestic violence shelter. So a lot of people who are there for physical or sexual violence are also going to be reporting reproductive coercion as well. Like I said, there are mixed demographic associations with IPV as there are with reproductive coercion, and really thinking that even though we want to recognize those who are at higher risk or more vulnerable, that as providers or folks who work in a healthcare setting, that universal screening is what's recommended and is most likely to convey the sort of education and support that we want to around violence against gender-based violence. And then this association with IPV, other tactics. So this kind of varies based on the study, and it's kind of unclear, I think, at this point in terms of our understanding of reproductive coercion. But if you look cross-sectionally, like in one moment of time, people who report physical and sexual violence, about 50% of them also report reproductive coercion tactics. And if you followed this people longitudinally, I don't know if all of them would say yes to both, but we know that in identifying someone who's affected by reproductive coercion, we're identifying someone who's at risk, significant risk of other forms of physical or sexual or emotional violence. So this, I think, is probably like a whole semester of classwork to like conceive of this, but I think it just, mostly is like me trying to get buy-in that there's benefit, particularly since you all are involved in the kind of health system, that there's a place for us to recognize and address violence in the work that we do. I think trying to do this in maybe 5-10 minutes instead of a term. It would start with acknowledging that violence is a major contributor to premature death, disability, and injury. And I think that's our primary task as healthcare providers, is to reduce anything that contributes to those ends. And I think it also is worthy to consider that violence is preventable, that it's not an inevitable part of our lives, but that it's something that truly there is hope and evidence that primary prevention is real and can take traction. And some of the things that folks have really looked into in trying to demonstrate that point, that I'm not an expert on, but have borrowed generously from a lot of violence work, is around temporal trends. So in looking at homicides over time in the US, why is it that there was such enormous variations in homicide rates over time, or by geography? And so looking at Salt Lake City does not make it into the top, whatever this is, 40 something. I think we're 49. There's a lot of geographical differences. These sort of, this inspection of data really was part of a trend within folks who study violence away from thinking about reactionary punitive measures to address violence towards a prevention-based measure with policies situated in scientific evidence. So I think it's also really good to know like what's going on in your state and your community. So, and interestingly, these are the FBI data from this year from Utah. That while Utah has lower reported rates of all violent crimes, there are higher, this is just a change of definition here, higher rates of reported rape. And so I think that, there's really complicated theories around why this might happen, but that and why these trends are happening, but that what we can do is use this model that's been really effective at things like car safety and like smoking reduction, to think about how we think about violence. And by having surveillance networks that allow us to collect robust data and to bring legitimacy to the role of violence in healthcare, we can start to create measures that are focused on effective and sustainable primary prevention. And that really started in terms of like a very truncated history of like actually addressing violence in healthcare, that you can go to the CDC and see this timeline, but really started in 1979 when the Surgeon General identified violence as a healthcare priority, and then the development of some really important surveillance networks to collect data, which prompted some standardized definitions around what are we actually talking about here, what are we measuring. Big times in 1994 with the Violence Against Women Act that really provided some dedicated funding to the creation of special forensic teams, prosecutors, the creation of a survey, a national survey. And now more recently, we're starting to see things like publications around effective measures to reduce dating violence in high school settings. So that is 2 years ago. So this is all like pretty novel, but exciting. And I think is really the future of what we need to look at in terms of research on violence is how can we not just measure prevalence or incidence or demographic associations, but how can we measure effective and lasting primary prevention models? And it's starting, I think, here. Okay, so this also, I think, has some upsetting material around specifically situating intimate partner violence and reproductive coercion into this idea of a healthcare quality of health indicator. So I try to term that as like who gets to be well kind of idea. And so I think it starts with this idea, if you can stick with me for, I actually don't know how we are doing in time. Woo, we're doing okay. But last kind of major point about violence is that gender-based violence is unique in that it affects such a large percentage of those who identify as women. It affects them in every aspect of their life. It frequently involves sexual offenses and is primarily committed by a known perpetrator. So those are things that I think are so powerful in understanding how to interpret the impact of intimate partner violence and reproductive coercion. And so examples of this, I think, include figures that show that most homicides of women are committed by intimate partners, or that there's no place that is safe for women from these threats. So the leading cause of fatal occupational injury for women is homicide, or that it may not even feel safe to be at school. And we know that very intimately here at the University of Utah. And I think despite some few highly publicized events, we're routinely kind of blinded to the prevalence and dynamics of violence against women. And so this is a really typical headline referring to a beloved member of our community who was killed by her partner. And this kind of idea of being shocked and disbelief is this classic, I think, homage to the invisibility of the issue. And there's no mention of intimate partner violence in the title. So I've done this talk in like 4 or 5 different cities, and I can find headlines that are the primary headlines that really don't mention what happened, what are we naming, and how can we publicly acknowledge what were the forces at work here. But it's not, that's kind of not part of the public eye. But there have been more recent efforts, I think most notably with the Me Too movement, that have allowed the burden of these lived experiences of women to come to our collective consciousness. This was a movement that was started by civil rights activists, Tarana Burke in 2007, and then popularized by social media largely in the last 3 years, with data from Facebook now showing that over 50% of users have had one or more friend post Me Too. And so these anecdotal, I think, data from our own lives or from our social media accounts is now also, I think, being legitimized by other studies. So this is from University of California in San Diego, Center on Gender Equity and Health shows that 81% of women report experiencing sexual harassment and assault. And so in this sense, I think that, and why I've spent a lot of time on this slide, is because it's important that we begin to understand that violence affects us all, but that those who identify as women are affected in a very particular way. And the intimacy and gender-based nature of these offenses may be impossible to separate from worldview, from notions of justice, from health-seeking behaviors, and from core identities. And so it's illustrating to me the centrality of this topic to the work that we do as leaders in healthcare setting. There are enormous costs to intimate partner violence, and thinking just in terms of dollars, $3.6 trillion lifetime economic cost of intimate partner violence in the United States, with only 2% of that related to criminal justice costs. A lot of that is coming to medical costs or lost productivity. And I'll focus in a little bit on some of the specifically sexual and reproductive health implications, but this is a study or a review paper from 2019 in the New England Journal that really goes into why is this happening. And it's because violence and chronic stress are thought to activate the neuroendocrine immune systems, accelerate telomere shortening, promote development of coping strategies like substance use, and then has these kind of distinct reproductive outcomes. Okay, so keep on moving. What we know about specifically the connection between reproductive coercion and health is that there's increased utilization of tests, increased utilization of emergency contraception, or what's often known as Plan B, of unintended pregnancies, decreased contraception use. And so the impact of reproductive coercion is likely much larger than what I'm illustrating on this slide. We just don't know because we haven't studied it yet. To go into this somewhat briefly, this is basically showing that this was in college-aged women, folks who showed up for 2 or more STI tests in the last 3 months, or showed up for 1 or 2 more, the asterisk being that it was statistically significant. Folks who are showing up for more pregnancy testing or STI testing were significantly more likely to report ongoing reproductive coercion. Kind of makes sense. I would call this as an important moment to recognize this as individuals engaging in a resistance strategy, rather than thinking gosh, what a waste of healthcare resources to us as people who are involved in the care of individuals. If we notice this, to think, gosh, why are they misusing healthcare? And think more deeply around what might be shaping folks' presentation for care, and this really important opportunity to ask more about what's going on behind these behaviors. Other things, and there's plenty of data around this, a lot of it again from college-age women, around effects on contraceptive use. None of this is surprising. Decreased contraception, decreased sexual self-efficacy, meaning ability to negotiate or ask for things that you would want in a sexual setting, increased use of emergency contraception, and then increased use of actually getting a sexually transmitted infection. And then unintended pregnancy, that concept, what is an unintended pregnancy, is actually incredibly complicated and is a big focus of the family planning community. And in these 2 studies, they kind of lumped together mistimed and undesired, which are 2 really different things. But either way, it's showing that folks who report an unplanned or unintended pregnancy are much more likely to report reproductive coercion and intimate partner violence. And then I'm not going to spend a ton of time here, but basically for a lot of times I'm talking to folks who are providing either pregnancy management, like pregnancy options counseling, or they're providing prenatal care. And this is something that we really see throughout the pregnancy and afterwards, impact of intimate partner violence. And we're starting to get data for reproductive coercion specifically as well. So in this sense, I think that while often we see one person, we see the one patient in front of us, that really we have to think beyond that and kind of think about the other spheres of influence that dictate people's health-seeking behavior and the counseling that would then inform appropriate care for them. For a lot of clinicians is that, and I think healthcare providers in general, people involved in the healthcare community, is I do not want to ask about intimate partner violence because I was not specifically trained to do that. And why does it it always is just me asking and then referring somewhere else. And it's me collecting data to then give someone else work that is beyond what I do. And I would argue with something as important as recognizing violence. It's okay if you're not the person who's responding directly to that. You're kind of creating space to create a referral. That's an amazing way you can change someone's life. But also with specifically reproductive coercion, and I hope in the future as we get kind of more ideas around primary prevention and kind of more robust data around secondary prevention for intimate partner violence at large, is that the healthcare setting is also the locus for responding. And I'm going to make that argument right now for reproductive coercion. I think starting with, in terms of primary prevention, is that screening is actually not an effort to promote disclosure as much as we feel like, are we going to get a yes? Are we going to get a no? It actually doesn't matter, because what it is doing is it's signaling to your patients that this is something that you care about, and it's providing universal education around phenomena that we recognize in the healthcare community as things that are important and affect people's health. And so I think really just holding on that in screening, we're actually providing critical information about healthy relationships, to me is what motivates me to ask every single time that I see a patient. But anyway, we've kind of created this idea, and OB-GYNs are the best at it, I will put the best at universal screening for intimate partner violence, but a lot of primary care providers have gotten very good about integrating intimate partner violence into assessment into their work. And I would argue that because there's this incomplete overlap between reproductive coercion and intimate partner violence, and because there's very distinct sequelae for reproductive and sexual health outcomes, that it's worth specifically asking about reproductive coercion. But in doing so in a trauma-informed way, and in a way where we recognize experts as survivors as experts, we have to recognize our mandated reporting status and really clearly disclose the limits to our confidentiality, so we aren't trapping folks in a situation where we then make a report that they weren't intending on, and potentially undermine their safety in that sense, but also really severely undermine their relationship with the healthcare community and kind of breaking that trust. So there are no validated instruments for screening for reproductive coercion, although that's something that I'm working on in my research. But this is what the American College of Obstetricians and Gynecologists recommend as some of the ways that you can phrase asking about reproductive coercion that I think are totally fine and you can use if you ever wanted to. The things that I really focus on for making the point to oftentimes providers is that these are the times when I feel like you cannot provide the best possible contraceptive counseling without acknowledging reproductive coercion. You cannot possibly talk to someone about barrier method use unless you know if reproductive coercion is happening. So these are the times that I also remind clinicians that if we want to provide the most nuanced and informed and appropriate care for an individual, these are kind of the moments when RC has the biggest impact. Again, I think recognizing that a lot of what we think of in terms of harm reduction strategies in the healthcare setting are actually informed by survivors. And so that's also something that in the future that I will hope to incorporate into research, is how can we actually gather more information from survivors into what are things that have been helpful in them retaining autonomy, being able to achieve their own goals. And so these are direct examples from the qualitative literature of things that folks have reported that they've done in order to keep in line with their goals despite their partner's interference. And you'll see that kind of come up in the next couple slides.
Dr. Faye, there's a question in
yes.
the chat box.
Yes.
It says, as an OBGYN, when a woman comes in expecting a child, do all the providers first ask if the patient wants the child? If no, is that followed up with asking about IPV question mark?
Yes.
Sorry.
So in the first prenatal care visit, the first thing that you ask is in wide variations of kind of sensitivity and interest, I would say, across the board, in terms of people saying, at least what I was taught was to say, is this a planned and desired pregnancy? And so people can say Yeah, it was not planned, it's desired. It was both unplanned and undesired. It totally is planned and desired. And so that gives you the opportunity to say, what is our actual branch point here? Is continuing with prenatal care the most appropriate thing? Or is it appropriate for me to talk about abortion options? Like, what are we, adoption? And kind of spend some time there to make sure it makes sense to delve right into prenatal care stuff. Regardless of what the answer is to that question, though, everyone per our national guidelines would also still ask about IPV.
Dr. Faye, what do you consider standard questions for IPV when you go down that route? What are kind of questions?
Yeah. So what, so the HARCS is like the thing that I think the University of Utah has on their, on Pulse. If, I mean, there's a whole host of gold standard, like validated intimate partner violence tools. I think a lot of them have a lot of specificity around specific actions. And so you'll see and hear often being asked, have you ever been hit, kicked, punched, pushed by a partner? Have you ever felt like sexually you had to do something you didn't want to do? Or do you ever feel like you just can't get anything right with this partner? And in that sense, you cover like physical, sexual, and emotional violence. I think there's still a lot of debate, and it's a field that's evolving around, are we asking folks in a way that doesn't ask them just to recount their victimization? But I would say that HARCS is the one that's most often kind of incorporated into the like clinic streamline. Correct me if you understand differently, but asking about and that's all on Pulse. So if you want to, or I think also in some dot phrases, so you can pull that in if that's something that works for you. I think I kind of try to build rapport and then in a gentler way kind of fold it in, because if it seems like you're not actually interested in the answer and you're just listing off physical violent acts, I think very often it's not going to make the connection you want. But stay tuned, maybe we'll have kind of more evolved ways of asking people about this in the near future. Did that answer the question? I kind of got off track there.
No,
HARCS is the one that a lot of people use. Okay, so very, very briefly, I've spent a lot of my time talking about contraceptive counseling. So things that people would talk about are there ways that we can make it easier for or harder for a partner to tamper or mess with those methods? Is your partner following your menstrual cycle? Do we need to do something that doesn't affect your menstrual cycle? Can I give everyone in the universe emergency contraception? Because that can help a lot. In folks who are presenting for that first pregnancy visit and want to know their options, and thinking about making sure people have access to urine pregnancy tests, they have access to emergency contraception, they have access to abortion care, and then talking about if someone is deciding to proceed with an abortion, talking about, does it make sense to have a medication abortion where medicines look like a miscarriage? Is it better for them to have a surgical, like a D&C, where you have one encounter, one time at a clinic visit, and fewer opportunities to interfere with pills? If someone's continuing with the pregnancy, does it make sense for them to get postpartum contraception in the hospital before they go home, like a shot or an IUD or an arm implant? Thinking about how folks who are affected by RC might need more frequent testing for STIs. They might need help with notifying a partner of a positive test to avoid violence or retaliation. They might be good candidates for pre-exposure prophylaxis for HIV. And then again, huge things like enormous concepts here of making the clinic office be a site for warm referrals. And that means like recognizing that folks might not be able to use the internet without having their history checked, or make phone calls without what phone calls they may be tracked. So having your office be a place where those things can happen, where you can have a social worker come in and make some connections. And so that we're not just, handing people a piece of paper that they're going to throw out before they leave the office so that their partner doesn't find that piece of paper. Trauma-informed care is a coursework of stuff that I think, I know that you guys have already reviewed, but the things that I try and think about is like actually, I think I have a slide in terms of some of the language, but like keeping lights on in the room, like not turning lights off, making sure the door is easily visible, having people stay as clothed as possible until whatever necessary exam part requires, clothing item removal. And then really asking folks for what has worked well for them before. So like a lot of times, probably every day, a patient places the speculum themselves because that is something that makes them feel in control, which is a very small thing that I can do and is super easy. So things like that, and patients usually have a good idea of what's worked well for them before or not. I think that you guys already know this, that to me, it was a little bit mind-blowing to me, like when I previously was an intimate partner violence advocate, that every state has a state coalition. And so I think a lot of folks in healthcare are moving a lot. So at least I have moved multiple different places for my training. And so it's meant relearning community resources everywhere I go. But the one thing that you always can count on is that there is a state coalition for domestic and sexual violence. Sometimes it's two separate ones. Sometimes they're housed in the same place. And that, like, the internet tells us lots of things, like, look at all these resources. You guys probably know more about that than I do, so I'm open to education. These are very basic things for some providers just to think through, for you all to think through as well, because I think we all have our best intentions, but sometimes our words can, in a non-intuitive way, actually not fall right for the person. So thinking, and again, intuitive, to say, I know exactly how you feel, or it's going to be okay, because both of those things actually might not be true. Talking about your experience or taking attention away from the person who's disclosing to you, or inadvertently kind of situating responsibility of someone else's behavior on that person. So why did you do that in response to violence? Usually not super productive comment. But this can be stuff that's high burnout. That I think probably it sounded like it was thematic with Marty's presentation as well, and definitely was thematic when I was an advocate. And the reason being, it's so complicated, and we often are bearing witness to people who we are really worried and scared about, but seem to have the same ongoing risks. And so that they're in really keeping ourselves situated in a space where we recognize survivors as experts, that the Department of Justice has excellent data to show that folks are at least 5 times elevated risk of homicide at the time that they try to leave. And so that there are a lot of good reasons why sometimes it's safer, or it's the situation that makes the most sense for the near future to stay with a partner, despite our how much that may challenge our perceptions of what makes sense. This is me just saying things are worth actually asking about. There's a little bit of data that says that patients are okay with being asked about reproductive coercion, that doing so is probably beneficial, and that providers are comfortable doing so once they're given some tools to ask about reproductive coercion. So again, going back to our things from the very beginning, reproductive coercion is very common. It affects basic health and autonomy, and that a lot of the ways that we can help combat this happens in the healthcare setting. Okay, not sure what time it is. Ooh, 5:50. Okay. Questions, concerns, comments? Actually, I see that there's some chat things that I should look at.
Yeah, there's one that comes up. It says the most recent one is, how has Utah laws made access to abortions easier or harder? Overall, I believe it has made abortions more difficult. Would you be able to discuss this? And then the follow-up question from the same person is, who has the rights to a child if the mother does not want the child, but the father does? Does the mother have to go to full term with the child? So 2 questions.
Sure.
There.
So I guess I'll start with overarching that generally speaking, Utah laws are focused on restricting access to abortion as the general political environment right now. And so this is a state with one of the longest waiting periods for abortion care, 72 hours. There's a state created abortion modules to help with decision making, but has not been studied or validated in doing so. And then very specific restrictions around like insurance coverage and sites where abortion can happen. And then every year, some gestational age restrictions are brought forward. So it's challenging, I think, although I do think that there's oftentimes productive conversations that are happening at state level that might not be happening in other states with similarly restrictive laws. So I'm hopeful that kind of there are fruitful conversations that help, I think, folks understand the importance of access to what is central to comprehensive reproductive health care. In terms of a fetus, I would say so a pregnant person who is still pregnant gets to make decisions over that pregnancy in their body up to viability, which is generally considered 24 weeks gestation. And so that's kind of their body, and there isn't input from the father of that pregnancy to that point, is the simplest way I think I can put that. Thank you for those very thoughtful questions. Other questions? You're welcome.
That was a thank you. Anything else? I think it's really, I'm optimistic hearing that you are really identifying and trying to come to some solutions with the screening and really the getting people talking within the healthcare system, whether that be a provider or even with this in our primary prevention with healthcare professionals, so nurses and social work and just other people who come in contact with people. I think understanding the background and everything about the potential of risk for harm is very helpful in understanding how to help in a primary preventive standpoint.
Yeah.
And there's another from Jessica. She wrote, great information as a victim advocate. I appreciate hearing IPV from a medical standpoint.
Awesome. If you have feedback for me, it's been a while since I've actually been in the advocacy world.
So I do have a question for you. If a pregnant woman comes into the emergency department and pretty much has their interaction with our RN staff, not necessarily a specialist like yourself, what might be some red flags that you should do a consult versus just sending them home, to get you all a little more involved if you see some red flags? Or, do you have any advice around that?
So yeah, I think that the folks that would be like other people involved, meaning like advocates?
Well, or just, if they're coming in and you actually you use all your techniques as a nurse to try to get maybe their significant other or someone out of the room to have a more intimate conversation, and you hear some red flags and you feel like, man, they probably ought to stay overnight or something to keep them safe.
Yeah.
What's the best venue to do that? Is it to consult one of you and you would admit them, or observation? What thoughts calling your community resources?
Yeah.
What do you think?
Yeah. So when I was an advocate, I would go to the hospital and we would go see people in the emergency room. And I am not aware of that happening here. Is that true?
We do in the emergency room, we do have access to our social
People come.
workers and our crisis workers.
The social workers, yeah, exactly. Sometimes it's helpful, I think, to have someone even like not affiliated with the hospital come, which is like what I would do, and just be like, I don't even have access to your medical record. I literally like walked in the door here. I don't know anything about anything other than can I be of help? But otherwise, yeah. So I think all the things that you said make a ton of sense in terms of asking folks. And I think we should probably do that for everyone where we can, interview them even for just 5 minutes by themselves, because you get so much just as like an obstetrician gynecologist, like not violence related, like a lot of changes in people's reported past medical history just when you can talk to them by themselves. And so that helps, I think, with just providing the best care to folks, is to give them an opportunity to disclose on their own. And then I think in that time, that's your window of opportunity to connect with folks. And if you do have concerns, I would say people are really good gauges of like genuine feelings. And so saying like, I'm worried and here are the things that I'm worried about. Like, is there something that you can think of that would be helpful? Here are some of the things that I thought about. Like, would it be helpful to stay here overnight? Would it be helpful for me to have a social worker come talk to you? Here are all the things that I have at my disposal that I'm happy to provide. And I'm just coming from a place where I'm worried. I think that would to me feel like very genuine. And Jessica, please, you're the expert here, jump in. I think if you're coming from a place that's like truly genuine concern, that will be read. And if you're doing that in a confidential space, then that also would be safe.
I would also think that, some of the people coming in may or may not, they may just find out they're pregnant, or they may not yet have started prenatal care. So making sure that we set up a follow-up for care, for prenatal care with somebody would be something. I don't know if that's done already, Jamie or Janet, but things like that, just making sure that they have follow-up care with an OBGYN.
Yeah. I found it like, yeah, totally. If you are getting a sense like this is like, I mean, the first time I learned about reproductive coercion was when a patient came to establish prenatal care with me as a first-year resident. And I asked the things that now you guys know. I was like, is this desired? Is this like planned? Like I'm told that's what I'm supposed to ask patients. I just became a doctor yesterday. And the person said, yeah, well, I don't understand because I just found out that my partner's been removing condoms. And so to me, this was like this hugely formative experience because it made me realize like I probably shouldn't ask questions of patients unless I know the breadth of answers that I could get back and really understand why am I asking this question and do I understand how to be compassionate with any possible response. And I did not fully understand. I didn't know what reproductive coercion was at that time. So I was just like, okay, is that changing how you feel? And kind of went down an options counseling route. But I think like if Janet, you were getting a sense or someone disclosed something that to you was like reproductive coercion, I have found that individuals find it actually can in general find it empowering to have a name for what's going on, because it can feel very othering or like there isn't, it can be so hard, like with all violence, to disclose and to say like, oh, I know what that is and you are not alone because this even has a name, can be powerful for people as well. And then to have that be a follow-up to care with an OB-GYN, and also have that be a preface with saying this is not to establish prenatal care necessarily, but to continue to have a conversation because so many folks experience what you told me to really flesh out kind of what makes sense in terms of next steps for you.
One more comment. I agree. I think having a word that defines people's feeling or experience is a step in the right direction for the patient. So again, and this leads right into our next month's topic is communication. So we're going to have a variety of speakers come in and, kind of the impact of your word as a, excellent. It is 6:01. Thank you, everyone. Excellent afternoon. So Dr. Faye, I think this was very great information for everyone. And I think we're all energized and participating, even though it's the end of the day. We thank everyone for attending and we look forward to some follow-up next month and